Hello everyone and welcome back to my channel. So we are going to discuss the most important topic from pediatrics and that is acute diarrhea. So we are having a scenario that there is a 1-year-old child brought to the hospital with 2 days of watery diarrhea. On examination he is irritable with sunken eyes, dry mucous membrane and is eager to drink. His anterior fontanelle is depressed and skin elasticity has reduced. Okay, so we are having now questions that classify the dehydration states and then specify the amount of fluid loss in terms of percent of the body weight based on WHO criteria and list the two criteria which helped you with classification in this and the 4 important steps of the management. So we will be discussing all these questions. Another scenario is that there is a 9-month-old infant has frequent loose motions and vomiting. He is taking mother milk as well as formula milk and semi-solid. His temperature is 99.5, respiratory rate 45 and heart rate 120 per minute. So what 2 important questions will you ask my mother as per IMNCI to classify diarrhea? What will you look for and feel as per IMNCI to classify diarrhea? Write down plan B management of diarrhea and what instructions will you give the mother while sending the patient home? So we will discuss the acute diarrhea in detail according to all these questions. 6 months old infant brought with complaints of vomiting and loose motion, same scenario, and here also we are having the same scenario. So let's discuss each thing one by one. We are having the definition of acute diarrhea, that it is the passage of 3 or more stools in a day of consistency softer than usual for child, or one watery stool is defined as diarrhea. The causes of acute diarrhea is infections of gastrointestinal tract are caused by a wide variety of enteropathogens, that is including bacteria, viruses and parasites, fungi, parenteral infection, dietary factors and drugs. The evaluation of the patient is done, that is first of all history is taken, then examination is done and then pathophysiology is done, that is loss of the water, loss of the nutrients, loss of the carbohydrates and potassium loss. So for this the investigations are done. Now the classification of dehydration is a clinical classification. We are having mild diarrhea, which is when weight loss is less than 5%, moderate diarrhea when weight loss is between 5 to 10%, and it is severe diarrhea when weight loss is more than 10%. The biochemical classification of dehydration is isotonic, that is in 70% cases when serum sodium level between 130 to 150 mole per liter. Hypotonia in 20% cases when serum sodium level is less than 130 millimole per liter. Then hypertonic, that is 10% cases when serum sodium level is more than 150 millimole per liter. Now the grading of the stools is done. Grade 1 is normal formed stools, grade 2 is soft stools, grade 3 is liquid stools taking shape of the container, liquid 4 is watery stools with flakes appears opaque in glass container, and grade 5 is watery stools with few flakes appear translucent in the container. The WHO grading helps in assessing the stool water loss and assess the progress, that is 3 to 4 and 5 worsening and 5, 6 and 3 improving. Now the investigation options are blood counts and the stool examination for pH and leading substances and cysts and amoeba, bioaccessory for E. coli, leukocytes and RBCs, culture and sensitivity, ELISA test for rotavirus. Serum electrolytes are done, that is sodium and potassium and bicarbonates are checked. Urine examination and culture for partial diarrhea. Blood culture is done for salmonella and shigellosis, and X-ray test is done for pneumonia. So these are the investigation options. The complications are dehydration and shock, metabolic acidosis, paralytic ileus, that is hypokalemia, convulsions and coma, that is hypernatremia, cerebral thrombosis and malnutrition, that is long-standing diarrhea, acute renal shutdown, persistent diarrhea, that is rice saccharide deficiency and superadded infections, thrush, diaper dermatitis, scleroderma, DIC and death. These are the complications of the acute dehydration. Now how we will do the assessment of the diarrhea for dehydration? We are having no dehydration, some dehydration and severe dehydration. So in no dehydration there is not enough science to classify as some or severe dehydration, and the treatment plan given for no dehydration is treatment plan A. For some dehydration, 2 of the following signs will be present, that is restless and irritability, sunken eyes, and the patient drinks eagerly and is 30, and skin pinch goes back slowly. The treatment plan B is given for some dehydration. For severe dehydration, 2 of the following signs, that is lethargic or unconsciousness, and sunken eyes, not able to drink or drinking poorly, and skin pinch goes back very slowly. The treatment plan C is given for severe dehydration. Now look for the Okay, for assessment, also the following things are seen, that is restless and irritability. Look for sunken eyes. Offer child fluid. Is child not able to drink or drink poorly? Drinking eagerly or thirsty? Pain skin of the abdomen. Does it goes back very slow, longer than 2 seconds? And if it goes more slowly than 2 seconds. Okay, now we will discuss the different treatment plans for the diarrhea, which is a treatment plan A for no dehydration. Counsel the mother on 4 rules of the home treatment, that is, these are the 4 rules. First of all, give the extra these are the 4 rules. First of all, let me highlight that, is give extra fluid, then the give zinc supplements, then then continue the feeding, and then when to return. These are the 4 rules of the treatment plan A for the no dehydration patient. This is give extra fluid, give zinc supplements, give continue feeding, and when to return. Okay, so give extra fluids as much as child will take. First of all, tell the mother that breastfed frequently and for longer at each feed. Then if child is exclusively breastfed, then give ORS or clean water in addition to the breastfed. If child is not exclusively breastfed, then give one or more of the following ORS solution. Food-based fluids such as soup, rice, water, yogurt, drink, or clean water. It is especially important to give ORS at home when the child has been treated with Plan B or Plan C during the visit and the child cannot return to a clinic if diarrhea gets worse. Then teach the mother how to mix and give ORS. Give mother 2 packets of ORS to use at home. Then show the mother how much fluid to give in addition of useful fluid intake. Up to 2 years, 50 to 100 ml after each loose stool and between them. 2 years or more, 100 to 200 ml after each loose stool and between them. Tell the mother to give small frequent sips from cup. If child vomits, wait 10 minutes, then continue but more slowly. Continue giving extra fluid until diarrhea stops. Then give zinc supplements, that is, tell the mother how much zinc to give. Up to 6 months, half tablet per day for 14 days, and 6 months or more than 1 tablet per day for 14 days. Show the mother how to give zinc supplements. In fact, dissolve tablet in small amount of expressed breast milk, ORS, or clean water in a small cup or spoon. Older children tablets can be chewed or dissolved in a small amount of clean water in cup or spoon. Remind the mother to give the zinc supplements for 14 full days. Okay, the third rule is continue feeding, that is, continue to breastfeed infrequently. Then if child is not breastfed, give cow's milk or formula milk half diluted for 2 days. If child is 6 months or older already taking solid foods after dehydration, give freshly prepared food like cereal with pulses, vegetables, or meat. Give food at least 4 to 6 times a day, and give fresh fruit juice or mashed banana to provide potassium. When to return? Advise the mother to come after 5 days for follow-up. Advise mother to return immediately if child has any of these signs: not able to drink or breastfeed, becomes sicker, develops fever, drinking poorly, or blood in stool. So this was the treatment plan A for no dehydration. Let's revise what we have studied up till now. Okay, we are discussing the case of acute diarrhea. That patient is having the history of passing loose stools and he is severely dehydrated or whatever. Then we are having the definition that it is the passage of 3 or more stools in a day of consistency softer than the usual for child, or 1 watery stool is defined as diarrhea. Then there are different causes which are infections of the gastrointestinal tract, and then we have to evaluate the patient. So first we will take the history, then examination, then the pathophysiology is checked. For pathophysiology, loss of water, loss of nutrients, loss of bicarbonates, and loss of potassium is checked. The classification of dehydration is done, that is, clinical classification of dehydration and biochemical classification of the dehydration. In clinical, we are having the mild, moderate, and severe, and in biochemical, we are having isotonic, hypotonic, and hypertonic classification. Then we will grade the stools. These are grade 1, grade 2, grade 3, grade 4, and grade 5. Then we will do the investigation options, which are blood counts and stool examinations, then serum electrolytes, urine examination, blood culture, and X-ray chest is done. Then we have discussed the different complications due to the diarrhea or acute diarrhea or dehydration. So these are the dehydration and shock, the metabolic acidosis, the paralytic ileus, the convulsions, malnutrition, acute renal churn, persistent diarrhea, superated infections, thrush, diaper dermatitis, scleroderma, DIC, and death. Then we are doing the assessment of diarrhea for dehydration. We are having no dehydration, some dehydration, and severe dehydration. So for no dehydration, we are having plan A. For some dehydration, we are having plan B, and for severe dehydration, dehydration, we are having plan C. Then we will look for the following things to assess the patient. Then according to the assessment of the patient, now we have classified that it is no dehydration or some dehydration or severe dehydration. So if it is no dehydration, then we are going to apply the treatment plan A. So we have discussed the 4 rules of the treatment plan A, that is give extra fluids and give extra fluids, tell the mother what to do, then teach mother how to mix and give ORS, then show the mother how much fluid to give in addition of usual fluid intake, and tell the mother to give small frequent sips from the cup. After that, the second step is give zinc supplements, that is tell the mother how much zinc to give and show the mother how to give zinc supplements and remind the mother to give the zinc supplements for full 14 days. Then we will continue the feeding, that is the third step, and then we will ask the mother when to return. So these are the 4 main basic steps of the treatment plan A in case of no dehydration. Now we will discuss the treatment plan B and the treatment plan C. So the treatment plan B is for some dehydration. Some dehydration. Okay, so the first step is give in clinic recommended amount of ORS over 4-hour period. So first of all, you have to determine the amount of ORS to give during the first 4 hours. For example, if the age is up to 4 months, then and weight is less than 6 kg, then the fluid is given in 200 to 400 ml. If the age is 4 to 12 months and weight is 6 to less than 10 kg, then 400 to 700 ml fluid is given. If the age is 12 months to 2 years, then 10 to less than 12 kg, then 7 to 900 ml is given. And same is here for it. If it is to 2 years to 5 years, then 900 to 1400 ml of fluid is given. Use child age only when you do not know the weight. Okay, the approximate amount of ORS required in ml can also be calculated by multiplying weight in kgs times 75. Okay, if you know the weight of the patient, then multiply it by 75, and the number that comes is the amount of fluid that you will give to the patient in case of some dehydration. Now for infants under 6 months who are not breastfed, also give 100 to 200 ml clean water during this period. The next step is show mother how to give ORS solution, that is give frequent small sips from a cup. If child vomits, wait 10 minutes, continue but more slowly, continue breastfeeding whenever child wants. After 4 hours, reassess child and classify child for dehydration, select appropriate plan to continue the treatment and begin feeding child in clinic. Then if mother must leave before completing treatment, then show her how to prepare ORS solution at home. Show her how much ORS to give to finish 4 hours treatment at home, then give her enough ORS packets to complete dehydration. Also give her 2 packets as recommended in plan A. Explain 4 rules of the home treatment, that is give extra fluid, using supplements, continue feeding and when to return. Then we are having the treatment plan C. The treatment plan C is for the severe dehydration. Okay, let's revise what was in the treatment plan B. It was for some dehydration, and first of all give in clinic recommended amount of ORS over 4-hour period. Then after 4-hour periods, reassess the child, and the third step is if mother must leave before completing the treatment, then show her how she will manage the patient at home. Now treatment plan C is for severe dehydration. First of all, can you give intravenous fluid immediately? If yes, then start intravenous fluid immediately. If child can drink, give ORS by mouth. If not, then drip is set up. Give 100 ml per kg ringer lactate solution, or if not available, then normal saline divided as follow. If the age is infant is under 12 months, then first give 30 ml per kg, then give if infant is 12 months, then give 30 ml per kg in 1 hour, and then give 70 ml per kg in the next 5 hours. If the general age is 12 months up to 5 years, then give 30 ml per kg in 30 minutes and 70 ml per kg in 2.5 hours. Repeat once if radial pulse is still very weak or not detectable. Reassess child every 1 to 2 hours. If hydration status is not improving, give intravenous drip more rapidly. Also give ORS about 5 ml per kg per hour as soon as child can drink, usually after 3 to 4 hours infant or 1 to 2 hours children. Reassess an infant after 6 hours and a child after 3 hours. Classify dehydration, then choose appropriate plan ABC to continue the treatment. Okay, so first of all, what you have done, you have given the intravenous fluid. Now if the patient cannot, we have a question here, that can you give intravenous fluid immediately? If yes, then we will give the following treatment. If no, then we will give the following treatment. That is, first of all, is the IV treatment available nearby within the 30 minutes. We will look for this thing, that the IV treatment is available nearby or not. If yes, then refer urgently to the hospital for intravenous treatment. If child can drink, provide mother with ORS solution and show her how to give frequent sips during tip. If no, then okay, we have two options. If yes, then this. If no, then we will provide this treatment, that is, are you trained to use nasogastric tube for dehydration? Start dehydration by tube or mouth with ORS solution. Give 20 ml per kg or for 6 hours, total of 120 ml per kg. Then reassess the child at 1 to 2 hours. If there is repeated vomiting or increasing abdominal distension, give fluid more slowly. If hydration status is not improving after 3 hours, then send the child for intravenous therapy. After 6 hours, reassess the child, classify dehydration, choose appropriate plan A, B or C to continue the treatment. Then the hospital management of the severe dehydration is then, that is, deficient therapy, concurrent losses, that is replacement of the ongoing losses. This is the hospital management. Deficit therapy, then concurrent losses, that is replacement of the ongoing losses. Then maintenance therapy, then fluids for deficit therapy, that is wrinkles solutions or normal saline. Then fluid for concurrent losses, that is 5% dextrose and half saline. Fluid for maintenance therapy, that is 5% dextrose and 1/5 saline. Electrolyte replacement, that is potassium replacement by carbonate in severe metabolic acidosis. Antibiotics are given and dietary management is done. Now the causes of the different infectious diarrhea are Vibrio cholera, E. coli, and Shigella, Salmonella, Campylobacter jejuni, Clostridium difficile, Giardia limpia, and Entamoeba histolytica. Now we are having the infectious diseases and non-infectious causes. Infectious causes are bacteria, virus, and parasites and fungi. The non-infectious causes are parental infectious causes and dietary factors and drugs. Okay, so we have discussed the plan C, in which first of all we will look that can you give the intravenous fluids immediately. If yes, then this treatment is provided. If no, then this treatment is provided, that is, then we will look if the intravenous treatment is available nearby within 30 minutes. If yes, then we will provide it. If no, then we will do the nasogastric tube for dehydration. The hospital management of dehydration is given below. Then we have discussed the causes of infectious diseases and the causes of diarrhea, and we are having both the infectious and non-infectious causes of the diarrhea. We are having the bacterial causes, the virus, the parasitic, and the fungi causes that are infectious, and the non-infectious causes are parental infections, dietary factors, and drugs. So we have discussed the most important topic from pediatric subject, that is the acute diarrhea and the management of the acute diarrhea. We have discussed the scenario first, then we have discussed the definition, then the evaluation of the patient, then the classification of diarrhea, which is mild, moderate, and severe, and biochemical classification, which is isotonic, hypotonic, and hypertonic. Then we have discussed the different grading of stools, which are 5 grades. Then we have discussed the investigation options and the complications. Then we have discussed the assessment of the diarrhea for dehydration, which are no dehydration, some dehydration, and severe dehydration. Then we have discussed the different treatment plans according to assessment of the diarrhea. For some dehydration, for no dehydration, we will give the treatment plan A. For some dehydration, we will give the treatment plan B, and for severe dehydration, we will give the treatment plan C. So the plan A consists of the 4 steps, that is, give extra fluid, then give zinc supplements, then continue feeding, and then when to return to the mother. The plan B is give in clinic, and that is recommended amount of ORS over the 4-hour period, then assess the child for after hours, and if the mother is living, then what she should do before completing the treatment. Then the treatment plan C is that can you give the intravenous fluid immediately? If yes, then you will provide it. If no, then we will go to the next step, and that is IV treatment available nearby? If yes, we will give it. If no, then we will go for nasogastric tube aspiration. And the hospital management of severe dehydration is also discussed here. Then we have discussed the different causes of infectious diarrhea, which are both the infectious and the non-infectious causes. In the next video, we will discuss the genetics chapter, and we will discuss the 3 main topics, that is the Turner syndrome, the Down syndrome, and the Klinefelter syndrome. Thanks for watching.